So, heart transplant today has become a standard therapeutic option for advanced heart failure. However, initially the mortality was around 11%. However, initially the survival was around 11% by the end of 1 year. Something which has improved it majorly is the role of immunosuppression. With the advent of immunosuppression and better understanding of it in the management of heart transplant patient, slowly the survival has improved to more than 50% by the end of by around completion of more than 12 years. With this brief introduction, I would like to invite Dr. Murtaza Chishti, Director Cardiac Surgery and Heart Transplant, Artemis Hospital, for his insight into, so that we can understand the subject more better way. So, sir, what is the goal of immunosuppression?
Thank you very much for having me here. As you rightly pointed out, immunotherapy, anti-rejection therapy has dramatically improved the results in cardiac transplantation. To put it bluntly and in a few words, the goal of anti-rejection therapy is to keep rejection at bay, all right, with minimum use of immunosuppressants and with minimal side effects, which are many, which we'll elaborate as we go.
So, sir, what are the common drugs we usually use nowadays for immunosuppression, and tell us something about their mechanism of action also.
Corticosteroids is the basically central drug in post-transplant immunosuppression, and it's used at every level, every shot, as we shall elaborate subsequently. Corticosteroids are sort of a general immunosuppression. They inhibit interleukin 1, 2 and 6. They also inhibit tumor necrosis factor and gamma interferon. And with these, they reduce both the activation as well as proliferation of T lymphocytes, which are crucial in rejection treatment.
Yeah.
So the corticosteroids are used in induction, maintenance, as well as treatment of acute rejections. And as you can recall from history, corticosteroids used to be the only drugs used in 70s, and you can go back in history and remember that the results were really dismal. And a bit later, azathioprine, which is an antimetabolite, was added. Azathioprine is basically, it inhibits DNA and RNA synthesis because it is an antimetabolite. It gets incorporated into DNA, and then the DNA replication stops, which means the lymphocytes and other cells cannot replicate anymore. And in the modern times, we have mycophenolate mofetil, which is similar to this, and that is superior to this older drug in the sense that it is specific for lymphocytes. See, there are two pathways for synthesis of guanine, which is important for DNA replication. See, the lymphocytes cannot use what's called a salvage pathway. So if mycophenolate prevents synthesis of guanine, the replication of DNA is stopped and lymphocytes cannot multiply, they can't increase in numbers. So that's why azathioprine is much inferior, because it affects all the cells, unlike mycophenolate mofetil or sodium, depending on which one you're using, acts selectively on lymphocytes and hence has got a much better side effect profile compared to azathioprine, the older drug. And the next class of drugs is called CNIs, calcineurin inhibitors. This also, calcineurin is a protein which is important and the initial steps for the synthesis of DNA, and which leads to synthesis of interleukin 2, and the further down the chain the lymphocytes can then multiply when stimulated by allo antigens. But the calcinurins inhibit this step and or a major advance in immunotherapy, the anti-rejection therapy. If you go back in history, when we had two drugs, one drug, corticosteroids, the rejection rate was very high. When we added azathioprine, the results were still not good. But when we used cyclosporin A in 1982, which is a calcineurin inhibitor, by the way, and that improved results dramatically. It transformed completely the scene of organ transplantation. So currently we have an additional cyclosporin, an additional calcineurin inhibitor available, that's called paclitaxel, and it has a better anti-rejection properties compared to cyclosporin, and studies have shown that it gives the incidence of rejection is less, and it has also translated into better survival. So these are the three which are very most commonly used. There are certain others. They are called Mtor inhibitors, right? And Mtor inhibitors include sirolimus and everolimus. You may recall from its use in coronary stents. They act on Mtor, that's the mammalian target of rapamycin, and inhibit the proliferation of lymphocytes. They are called actually proliferative signal inhibitors. Okay, and these have a special place in management of organ transplantation. And of course, there are some other agents which are used in acute rejection.
So is there any standard protocol regarding the uses of these drugs, or is it?
Actually, there is no standard protocol. Different centers, different surgeons use different protocols, but basically there are some basic similarities. The basic principles are well established, but standard protocol is none.
And when we start a case, is there something like induction or something we do use something, or is it like used in almost universally?
Yes, for anti-rejection therapy there are mainly three categories. First is the induction therapy, second is maintenance, and third is treatment of acute rejection, right? Induction therapy means you pulse the patient with certain agents, certain immunosuppressants, and so that you get you knock off the immune system so that you protect the organ, right? This is a bit controversial, which is because 50%, maybe around that number, use induction therapy, and 50% don't use it. It has an upside. Upside is it reduces the rejections early on, and you can use induction therapy to delay calcineurin inhibition in the post-operative period in patients who have kidney dysfunction, for example. Okay, and the downside is it increases, the induction therapy increases the incidence of infections, and probably also the development of cancers in the long term.
So there is no proven role as such that definite clinical evidence regarding that they do have some, where the cases group which we didn't use induction therapy and the group which we used, there was not much of advantage was there in the group where induction was.
There is no proven survival benefit, but in certain situations we would definitely use induction therapy. For example, as I mentioned, in patients who have kidney dysfunction, for example, and also in patients who are sensitized, who have greater chance of having been sensitized. For example, somebody has a history of pregnancies or blood transfusion or previous heart surgery, or there's an LVAD in place. So you might prefer to induce these people rather than go straight to maintenance therapy. In any case, induction with steroids is done in all cases.
All the cases.
So there's another agent that's called basiliximab, and that is used in addition to ATG to induce. But you know, the steroid induction we use in all cases, but we don't call it induction therapy.
Induction.
Okay. Yeah.
Sir, in case of maintenance treatment for immunosuppression,
Yeah.
why do we use combination of drugs rather than monotherapy?
See, if we look back, single drug didn't work that well. That was the steroids. And then we added azathioprine, didn't work very well at all. And then when cyclosporine came on the scene, it changed the entire scenario. So we have learned from experience that 3 drugs work better than 2, or certainly better than 1. And also there's another reason, which is a pharmacological reason. When we use multiple drugs which act at different levels along the chain that leads ultimately to proliferation of lymphocytes that have a role in organ rejection, then it's more effective. And each drug, the side effect of each drug is kept low.
So what is the current combination, like the one which is most commonly used?
The most common combination for induction therapy is usually, I have already mentioned steroids. In addition to that, we use basiliximab. Basiliximab we usually use 20 milligrams before surgery, let's say 1 or 2 hours before induction anesthesia, and then we use another dose at of 4 post-operative day, right? And we also use anti-thymocyte globulin. We use about, let's say 1 to 1.5 milligrams per kilo, and that has to be given very cautiously through a 22 micron filter over at least 6 hours before surgery. And then we repeat this at day 1, 3 and 5, all right? So steroids plus basiliximab and ATG, this constitutes the induction therapy. These are the 3 agents used. As far as maintenance is concerned, there are 3 classes, as I have already mentioned. Number 1 is the corticosteroids. Number 2 is the calcineurin inhibitors. Most commonly is tacrolimus, because tacrolimus has given better results compared to cyclosporine. And third is mycophenolate, which is an antimetabolite.
So as you discussed, sir, you told us that there are few side effects even. So is there something, one of the reasons to use induction is they help you spare with, for some time you can delay the initiation of calcineurin inhibitors, and is it?
Yes, that's one indication. If you have someone who has got kidney dysfunction. And then you don't want to use a nephrotoxic drug like tacrolimus early in their post-op period. So in those patients, I think should be induced, as we have discussed, and then you have to see what happens to the kidney function. If the kidney function improves sufficiently, then we can introduce tacrolimus. It gives us time, maybe, the effect of induction therapy loss maybe up to 60 days. So we have plenty of time to let the kidney recover and start calcineurin inhibitors at a proper time. Suppose kidney function, there's a primary kidney disease. The kidney dysfunction was not merely because of poor cardiac output before surgery. It was because of kidney disease, and that kidney is not going to recover much. So in that scenario, you may not choose to use tacrolimus. In that case, you might either use only sirolimus in combination with other 2 drugs, or you can use a smaller dose of tacrolimus.
Is there any new role coming up with early use of statin, or somewhere initiating? When should we start statin, and what is the advantage with the statin?
Actually, statins are very interesting drugs. They have got not only cholesterol lowering property, they don't just have anti-inflammatory properties, they also are immunosuppressants. And it has been shown that they improve survival and reduce the incidence of rejection, so they should be part of the immunosuppressive regimen, even though it's not called an immunosuppressant, but it helps
Maybe an
keep rejection.
immunomodulation.
It's an immunomodulator basically, and it should be given to all patients regardless of their cholesterol level.
How early should we start? Should we watch the creatinine and then consider starting, or maybe by the completion of 7th?
So are you speaking about statins? Statins really don't have anything to do with the kidney function.
Okay.
Yes, you need to make sure that the liver function is okay. Then they can be started as early as possible. We started like you start in a CBG patient.
So after learning of immunosuppression, now we would like to know about the types of acute rejection and when and how is each treated nowadays.
See, rejection is basically acute rejection is basically of 3 types, I could say. One is hyperacute rejection, which is a rejection which antibody mediated, which happens because of preformed antibodies in the recipient, again as the donor tissue. So this should be distinctly rare in this day and age, given the careful matching which is done between the recipient and the donor. Previously we used to do prospective matching. We used to match the donor cells with recipient serum. That was called prospective matching, but that has got geographical limitations. We can't do it if the donor recipient are at geographically different places. Now we have got a very good thing that's called virtual cross match, in which we check HLA antigens in the patient, and then there's a system in which they match prospective donors with the potential recipients. And this virtual cross match has really helped us, and the hyperacute rejection should be a rare event, which leaves us with acute rejection, which is not hyperacute, acute rejection. And acute rejection can be either cell mediated or it can be antibody mediated. The cell mediated rejection is usually treated, it depends on the grading. You have to do an endomyocardial biopsy, which is still the gold standard for checking rejections, and it is graded. There's a revised grading now. Grade 0 is nothing. Grade 1 is when there is mild rejection. Grade 2 and 3. So depending on the grade of rejection and depending on the patient's clinical status, whether or not his heart function is affected, whether or not hemodynamics is affected, that determines treatment. Let's say if someone has got grade 1 rejection, there is no hemodynamic impairment, you don't need to do any treatment. If there is hemodynamic impairment with grade 1, you have to treat it with steroids. Usually oral can be pulsed oral, like you give 1 to 3 milligrams, some people get 3 to 5 milligrams per kilo for 3 to 5 days. You can give methylprednisolone IV as well, but there's not much of a difference. The bioavailability is similar between these two. And if it's a grade 2 rejection without hemodynamic compromise, then you give them the same treatment as for grade 1 with hemodynamic compromise. If grade 2 is associated with hemodynamic compromise and or the patient has got a grade 3 rejection, then we add anti-thymocyte globulin to steroids. Okay. So this all depends on what the grading of the thing is. And of course then you have to follow them up with weekly biopsies, and then you depend on that. If there's a refractory steroid resistant rejection, for that you use rituximab.
Okay.
Right? So rituximab is usually 375 milligrams per square meter, and then you go on and on with that. Now the other type of rejection is antibody mediated rejection, less common but more serious. See, its treatment is given only when it is associated with hemodynamic compromise, or LV ejection fraction is less than 40%, 45%, or in the previous, from the previous known value, it has dropped by more than 25%. That's 1/4. So those people we treat. Others we don't treat. We treat them only because the treatment of antibody mediated rejection is very intense, and can be associated with very serious side effects. You know, and so it's basically treated with plasmapheresis, and the protocol is published, so we can always consult that. And the OKT3 was used previously, which is not used anymore. Basically, that is the fundamental treatment.
So this is what the acute problems we face with
Yeah.
with the immunosuppression and rejection and all. It's something which you feel like in the later once that 1 year period is over and with the
Yeah,
continuation
there are a couple of things that can that happen in the long term, which are really bad. One is called you know, cardiac allograft vasculopathy, in which there is coronary artery disease happens. It's distal and it's diffuse. You can't really do much about it once it is established. And the other thing is development of cancers in the long term. Usually skin cancers, could be you know, lymphoproliferative syndromes. Any cancers can happen, but these are the two commonest cancers. And for both of these two things, there are ways to prevent them, reduce their incidence, and sirolimus is emerging as an important therapy to prevent these cardiac allograft vasculopathies, as well as reduce the incidence of cancers after solid organ transplantation.
Thank you, sir. I think the topic is too vast to be covered up, but thank you for enlightening us and improving our knowledge about regarding heart transplant immunology.
Thank you very much for having me.
Thanks.